Thank you very much, Oscar. Vivek Reddy is known to everybody. He honestly needs no introduction, as we all know, but I'm going to give a very brief one. I think most of you know that he's the director of the Arrhythmia services at the Mount Sinai Hospital and the Mount Sinai Healthcare System. He also serves as a chair for the Leona M and Harry B. Hemsley Charitable Trust as a professor in medicine, cardiac electrophysiology at Icahn School of Medicine at Mount Sinai. I think one of the things that really is good about Vivek, and the reason we wanted him to participate in this session, is he really has approached arrhythmic issues and the innovation in arrhythmia from multiple perspectives, whether that be pacing, whether it be defibrillation, whether it be ablation, or whether it be thromboembolic risk reduction. So he's got a very broad perspective. He also has, I think, characteristically been always innovative. He's thinking out of the box. He sees a gap and he builds a bridge. And it's not a wooden one, it's a steel one. It starts out wooden, he addresses it, and it becomes stronger in steel. He clearly has been able, and this is what I've been really impressed with you, Vivek. You've been able to engage people as partners, both industry and colleagues domestically and internationally, to bring together our entire specialty, which is what we try to do within the field of electrophysiology. And then you carry it into education. So we're really honored and we're really pleased to have you give this keynote speech. And what we're asking you to do is look at our field, where we've been, where we are, and where we're going, from evolution, which is what we've been, to perhaps revolution, that is new changes. So looking at how the evolving arrhythmia technologies that are now in the barn being investigated or are already present in our tool shed can be used to revolutionize arrhythmia care. We look forward to hearing your perspective as you give us your presentation. Thanks for joining, Vivek.
Thank you so much. Thanks, Oscar, and thank you, Tom, for both the very kind invitation and the honor of being able to present, and this very, very kind introduction. So I'm going to go ahead and share my screen here. Let me just give me 1 second. Hopefully I won't have too many issues. We will see. Okay, good. So let me just flip these and hopefully you'll see the right screen in just a second. Okay, good. So hopefully you're seeing the right screen now?
Yes, we are.
Great.
Perfect.
Okay, fantastic. So before getting started, please note that I do have a number of disclosures, and I will be discussing about devices that do not have regulatory approval in several regulatory environments. So my charge is to discuss from evolution to revolution. I guess I'm going to focus more on the revolution. And there's 6 different aspects I'd like to cover on: AF ablation, stroke prevention, ventricular arrhythmias, leadless pacemakers, something I didn't think I'd ever be talking about, which is syncope, and then finally, just a word on AI. Let's start with pulse field ablation. And I put this in the context that all of the evolving data from the clinical trials, whether it be East AFNet or some of the first-line ablation trials that have pushed rhythm control up to the forefront of our management of atrial fibrillation, and the role that catheter ablation is currently, and I think will play in the future. Pulse, if we think about ablation, we think about how we currently ablate. With thermal energy, whether it's RF ablation or cryoablation, fundamentally we're ablating with heat, and as the thermal wave propagates, or cold, and as the cold wave propagates, we can cause damage not just to the atrium that we want to damage, but to surrounding structures. So we're always balancing safety and efficacy. Now, pulse field ablation is a fundamentally different approach that doesn't use thermal energy largely. Instead, it uses high-intensity electrical fields to cause cell destruction in a non-thermal fashion. It causes cell permeabilization by a variety of mechanisms, including pore formation, and ultimately results in dielectric breakdown of the cells. Why is it interesting? Well, it's fast, which is good, but it also has some degree of tissue selectivity. We don't fully understand why, but we know it's there. And so here's one of the first pulse field ablation catheters. A field is created. The electrograms, as you see here, are isolated very quickly. And in this image from Fabre-Clocher and Piaget, what you see is the delayed enhancement ablated tissue in yellow in this homogeneous pattern around the pulmonary veins. Now, what's really exciting is this. Unlike with cryoablation or radiofrequency ablation on this MR image, where you see the ablated esophageal tissue adjacent to the cardiac tissue, with pulse field ablation, we don't see the damage to the esophagus. And that's, I think, one of the most interesting aspects of this. There are other interesting aspects. If you look at LA strain, for example, there's less strain with both pulse field and thermal ablation, but with thermal ablation, it stays abnormal, but with pulse field ablation, it largely normalizes. Another important aspect. Clinically, the early data looks good in terms of freedom from atrial arrhythmias. This is first in human trials and a very large multi-center randomized trial just completed enrollment comparing pulse field with thermal ablation. We're now in the follow-up phase. I do want to note this is a recent manuscript that we had looking at the first 1,700 patients treated clinically post-approval. Acute success is quite high. And this is a survey, so we have to be careful how we interpret this. But importantly, if we think about some of the selective aspects of pulse field, what we see is no esophageal injury, no PV stenosis, or no phrenic nerve. Again, this is a survey. We have to wait to see how follow-up trials will not to corroborate this. Let's move on to mechanical stroke prevention. We're all aware of various devices that have been designed to fundamentally take the appendage out of the equation. There are 3 randomized trials, PROTECT, PREVAIL, and PROG-17. And if you look at this meta-analysis, what we see is that overall stroke rates are similar. A few higher strokes, ischemic strokes with appendage closure, balanced by fewer hemorrhagic strokes. And interestingly, also less mortality. Now I want to focus on.
Excuse me, if you're not, could everybody please mute their phones if they're talking, so there's no distractions? Thank you.
Thanks, Tom. So there's 2 interesting aspects that I want to talk about, which are emerging. The first is the issue of stroke severity. So overall stroke rates are similar with appendage closure versus or anticoagulation. But what's interesting is there's some data now that even ischemic strokes may be less severe in the context of appendage closure versus NOACs. This is an interesting study, and there's more that are becoming, looking at ischemic strokes after or while receiving NOACs or ischemic strokes after appendage closure. And what you see, if you look at the modified ranking score, is that compared to baseline with or anticoagulation in dark blue, you see that there's an increase in the modified ranking score, versus with appendage closure, it's actually not as high of an increase. So they do appear to be less severe if occurring in the presence of appendage closure than NOACs. So why might this be? Well, perhaps if the appendage is occluded, you have less thrombotic burden, or perhaps in the presence of NOAC, you have superimposed bleeding to the brain infarct. Again, there's emerging data, and we should stay tuned. The other interesting aspect is this. This is an interesting analysis, and I think it's be published very soon, where we looked at patients in the randomized trials, and over 1,000 patients where we had very good TE imaging at 45 days and 1 year. And what we found was that of the 28% of patients that had some degree of leak at 1 year, what you see is that compared to no leak, if you had some degree of leak, the subsequent ischemic stroke rate basically doubles. Okay, so this is over the subsequent 4 years. This is interesting for 2 reasons. One, we need to keep these data in perspective. Ischemic stroke rate in this appendage closure cohort, warts and all, including the leaks or not leaks. And notice that it's similar to what's expected for anticoagulation. Of course, both are better than if you don't treat with anticoagulation. If you look at what percent of these patients, about half the strokes, or half these patients who had strokes had some degree of leak. And this is very interesting because if you look at those patients who didn't have leak, you have a subsequent ischemic stroke rate of only 1.2%. So this gives us some glimpse into the possible. If we could occlude the appendage without having any leak, we could have extraordinarily low ischemic stroke rates. Now, is that a pipe dream? Is this reasonable to think we could get there? Well, I think the answer is yes. All of that data was with the original Watchman device. Now we have the Watchman Flex device, and with the Flex device, the leak rate is already lower from 28% down to 10%. And then with next generation deflectable sheets to facilitate how we implant the device, we might be able to get this even lower. So I think I'm actually very optimistic about the future of these devices. And certainly we'll see these data in the large randomized trial, Catalyst and Champion, which are 3,000 patient trials comparing appendage closure to NOACs. So these are ongoing trials. Let's move on to ventricular arrhythmias. with SCAR VT, with VT in general, these trials are very difficult to run. And yet, over the past 6 months, we've had 3 trials that have been published on VT ablation, randomized trials. I just want to highlight one of them, Partita. Paolo Dellabella and his colleagues took 517 patients who are receiving primary and secondary prevention ICDs. And those patients that had an appropriate shock were randomized to either ablation or not. And what was seen, and they had to stop the trial early for efficacy, the primary endpoint of all-cause death and worsening heart failure hospitalization was improved in the ablation group in red compared to standard therapy with an NNT of 3. Stunningly, this was largely driven by mortality with an NNT of 3.4, which seems to be related to decreased VT recurrence with shock. Again, this is a small study. We have to be careful how we interpret this. But as we think about the disease progression of SCAR-related VT and how we deal with these patients at the time of implantation, after a shock or after shock plus therapy, there have been trials, they're now emerging trials, and there'll be additional trials. So I think we'll have a much better understanding of exactly when to intervene on patients who have SCAR VT. And particularly exciting, the next generation ablation catheters, including pulse field catheters, I think have real potential. This is a SCAR model, and when we ablate on top of the SCAR, the pulse field lesion can go right through this. So I think this has real potential for how we deal with SCAR VT. I also want to highlight some work that Michelle Hasseger has published recently. Patients who have VF that have these so-called triggers where they have a PVC that the same morphology initiating VFib, we know now that if we ablate these PVCs, we can reduce the burden of VF. What's new that Michelle and his colleagues recently published is they looked at the activity of the so-called, what he calls organized VF, the first couple of seconds after VF is induced. And what he found was that if you look at the Purkinje network, you can actually see how it may drive this. So this is an example, induced VF with program stimulation. You can see the Purkinje potentials that seem to drive this VF. And importantly, when you target this, you reduce the amount of VF compared to before versus after. And this is your freedom from recurrent VF. Again, I think this is extremely exciting, the idea that we could potentially even address the substrate of VF. Let's move on to leadless pacemakers. They were the first in human trials, followed by some of the regulatory trials with 2 different devices. And then we don't have randomized data compared to standard therapy. But if you look at this propensity match analysis, for example, what we see, and I think is going to prove to eventually be true in randomized trials, is that with leadless devices here in teal, you'll have fewer reinterventions and fewer chronic complications, though it's unlikely to affect mortality. Again, this needs to be proven in randomized trials, but certainly they've entered our clinical practice in a big way. What's next here? Well, I think it's going to be this. It's going to be dual chamber leadless pacemakers, where you have 2 different devices that need to be able to communicate with each other. And this is already here. This is a preclinical study where we presented showing that the so-called eye-to-eye communication is very high, 98% eye-to-eye communication. And we actually just commenced the dual chamber leadless pacemaker trial. And here's an example of a device in the ventricle and a device in the HO that can communicate with each other. Again, this is part of an ongoing FDA trial, so we need to wait to see what the data looks like. But will this be sufficient? And I think the real question is, will leadless pacemakers be able to, let's say, interact with the emerging data that we have that physiologic pacing may improve patient outcomes? And I think this is the real challenge for leadless pacemakers. I'm optimistic that they'll be able to meet the challenge. Okay, let's go on to syncope. I think this is some work that was really pushed forward by Jose Pachon and his colleagues. And this is the concept that cardioneuroablation can treat vasovagal syncope. That is, you can target these periatrial ganglia, and by doing this, and particularly these 2 locations, the right superior ganglia and this inferior ganglia, and I'm just taking you through one of our examples. You can pace in the internal jugular vein, and you can pace the vagal nerve. And what you do with the cervical vagal stimulation is you can cause this intense sinus arrest. If you then ablate the right superior ganglia, you have sinus rhythm. Of course, you still have AV block. And then if you ablate now the inferior ganglia, you abrogate this vagal response. And interestingly, there have been a number of non-randomized studies, including over 300 patients, showing that this seems to be highly effective. There's no published randomized data, but this is data that was presented 48 patients randomized, not placebo, but still randomized between cardiac ablation and control. And a follow-up 2 years, there was a recurrence in syncope was 50% in the control group, only 4% of cardiac ablation. So I think very exciting. We still need to see some more data, but this is, I think, is going to transform the care of some patients, because as all we know, some of these vasovagal patients are highly symptomatic, and there's not that much else that we can offer at this point. Finally, AI. I mean, in the last, I guess, 3 minutes, I'm not going to do justice for all the work that's being done in AI, the Mayo Group and Hopkins and a number of different institutions around the country and around the world. But I do want to highlight just one thing that I as a clinician have sort of taken away, and I just want to give one example. This is some work from the Mayo Group, looking at AI and looking at the EKG to predict aortic stenosis. So they took patients who had EKGs, 200,000+ patients, who also had echoes. They they said, okay, look at the EKG. This patient has AS, this patient doesn't AS, and they trained this convoluted neural network. And then when they tested this, they found it was actually, quite good, that they saw good sensitivity and specificity. Okay. Now, the other thing they did, which was very interesting, was so-called saliency mapping. So you can look at what on the EKG was actually, did the convoluted neural network actually take into account that actually drove its sort of understanding and prediction of AS. And what you see here in the blue is indicative. And notice that this right anterior precordial location, it actually seems to be looking not just at, but also at the U wave. So U waves in the anterior precordial location. And so we just recently published this. We thought it was interesting, looking at precordial U waves in severe AS and who are undergoing TAVR. And what we saw, looked at 50 patients who are undergoing TAVR who had severe aortic stenosis. What we see is U waves in 62% of the patients. And by the way, in a control population of 50 patients on the medicine service, it was only 12%. So highly statistically significant. Also interesting, if you then do TAVR, the U wave is shown here, diminished in 87%, of which 74% was eliminated altogether. I show this because I think that we can learn from AI. There's clinical, hints that we can get, pearls that we can potentially get. And I think we need to, as clinicians, interact with AI more and more so that we can become better clinicians. So with that, I think I'm going to go ahead and stop because I've just used up my 15 minutes. Thank you very much.
Vivek, thank you very, very much for that great presentation on where we are and where we're going. It certainly, really does indicate, you demonstrated very nicely, the opportunities that we have. I'll just ask you one quick question and then we'll move on. Given all the things that you're describing and all the trials that are ongoing, what do you see typically going to be, and I know this is a very broad question, but in 5 or 6 years, how are arrhythmia patients going to be managed? I mean, right now they're oftentimes undermanaged and they're referred late. Do you think, in addition to these technologies becoming apparent, assuming that they all or most of them pan out, how do you think systems will evolve to deliver care appropriately, given the cost considerations here?
Whoa, I think you just asked 5 really hard questions in that question. But I guess let me just focus on AFib for 1 second, and I'll just make one comment. I think that, I think rhythm control is very clearly going to be very important. Okay, this has been shown with Paulus and John and everyone else who did East AF. I think that catheter ablation is clearly the best way of achieving rhythm control. I shouldn't say the best, it's the most effective way. And I think with pulse field coming to the fore, where procedures will definitely be under an hour long and probably under half an hour with incredible safety done as outpatients, that's going to come to the fore. So I think that there'll be a lot more AF ablation done. I think that this will be in the context, though, that there's probably going to be more work that's going to be done on autonomic modulation, perhaps even earlier, before we even think about ablation, perhaps even before we think about drugs, at the time where we start seeing PACs. And I think helping all of this will probably be things like, GLP-1 inhibitors. We've all seen how weight reduction may now actually be possible with some of these new medications. And Prash and his colleagues have shown us how important that is in the management of AFib. So I think that that's what we're going to see. And I guess the only other caveat to this I'll add is that there are going to be, I think, interactions with structural interventions. I believe that if you look at heart failure, anything that decreases left atrial pressure is going to improve AF outcomes. So whether that's things like MitraClip or whatever, dealing with the mitral valve, or other heart failure management approaches to decrease left atrial pressure. So my guess is that a combination of structural, let's say nutrition or patient sort of behaviors and autonomic modulation are going to all be used and have to be used to treat these patients.
Thank you very much again, Vivek, for this great presentation. We appreciate you joining us. I'll hand it back to you, Oscar.
Vivek, as an old cardiologist, I was saying, my last two words of your presentation are that, fortunately, your challenges presentation is that we are going to have our patients in less risk, just with all developments in different possibilities, and that's very important. Thank you so much for your presentation.